interrupt your CPC, but this could be also, we can consider this a CPC case as well, when we go back, where we have the diagnosis and we go back to treat the patient. You have heard about this before. The reason why we are bombarding you with this, telling you about this study is because we will actually need your help to enroll the patients in this study. The patients have to be enrolled immediately after, as soon as they hit the ED. So you will be the one who will be enrolling the patients in this study, because it's about the status of epilepticus, and we have to treat them immediately. So it's a really exciting study, because it will actually change our practice. It will create evidence for what we will do for these patients. So you will be part of this fantastic study, generating high-level evidence, and you might go to heaven. unless you like warmer climates. That can be arranged as well. So the study is called Establish the Status Epilepticus, and established means status epilepticus that is resistant to benzodiazepine. So the first line of treatment is benzodiazepine. We have really good evidence that benzodiazepines work, and they stop the status epilepticus if you give the right dose. For those of you who were at the All NYC lecture, you will remember that you have to give adequate dose of benzodiazepines for the seizure to stop. So if you give adequate dose of benzodiazepine and the seizure doesn't stop, then you're dealing with established or benzodiazepine resistant status, and your next option is, what do you usually give? The second line of treatment. You have phosphonatoin, valproic acid, or Keppra. It's mostly personal preference, or if the neurology is around, they might suggest one medication or another. We don't really have a good evidence which one of these medications are more effective, and we don't know which ones are safest. There has not been any study that compared these head to head. So the objective of this randomized controlled trial is to compare the efficacy and safety of these three medications. The main outcome is cessation of seizure within 1 hour of giving the medication without the requirement of any rescue medications. So these are the three medications that you're going to compare head to head. Phosphonatoin, 20 milligram per kilogram. This is, the dose is 10 to 20, but we want to give maximum dose of phosphonatoin. Levetiracetam or Keppra or valproic acid. These are the doses that the patients will get. This is it's a rare study because it's we managed to get exceptions from informed consent, so you don't have to consent the patients. How EFECT works is we actually get the consent from the community. So we go to the community, we present the study to the community, we hear the concerns, we go to epilepsy clinics, epilepsy groups, and we present them the study, and we will tell them, we've done this already, we tell them about the study, but we have argued that if the patient comes in, they are altered, they need immediate treatment, and therefore we will not have time to explain look for the legal authorized representative. You need to enroll them immediately in the study. Because we have informed the community, we have given people the option to opt out. So if someone has a child or someone has epilepsy and they don't want to be in the study, we have bracelet that we give them. So in case they have a seizure in the street and someone brings them to the ED, they won't be enrolled in the study. That's an opt-out option. We also have a piece of paper, it's no objection. So if someone comes with brother, sister, mother, we give them while we enroll the patient, we give them the piece of paper. And they can read about the study, and if they don't want their loved one to be enrolled in the study, they can tell us, we don't want the patient to be enrolled. But in general, as soon as the patient hits the ED, we can start enrollment. No consent is required. There are three main eligibility criteria. One is age. We enroll patients older than 2 years old. The status has to be convulsive status epilepticus, and the patient should have received adequate dose of benzodiazepine. We break them down into three age group: 2 years to 18 years, 18 to 65, and more than 65 years old, or geriatrics. So again, the seizure has to be convulsive status. It's okay to have focal seizure that has now turned into full-blown convulsive status, or sometimes people start with convulsive status and they turn into the focal seizure. As long as there is a convulsive component, generalized tonic-clonic component to it, that's okay. No focal status, no non-convulsive seizure, no subtle status. So the minimum dose of benzodiazepines are listed here. This is minimum dose. So the patient should have received at least this much by either EMS, ED, or family member. So we just quickly ask them, did you give any benzodiazepine en route? We ask family if they did. Sometimes they give rectal diazepam. EMS might give them IM midazolam. So as long as they have received this dose, they have received the minimum dose of benzodiazepine, and if they're still seizing, they are most likely benzodiazepine resistant status epilepticus. However, so this is the list of our exclusions. Nothing unusual. We want to make sure that the patient should have been seizing for 5 minutes at least. We want to make sure that this is a status epilepticus and not just a seizure episode, right? We should give benzos sometimes, so we give them 5 minutes to for the benzos to work. So if someone comes and they haven't received any benzodiazepines, assume they have no benzodiazepines, we give them adequate dose of benzodiazepines and we wait 5 minutes. If it doesn't stop, then we are dealing with established status epilepticus. And if it's more than 30 minutes from the last dose of benzodiazepine, you need to redose. You need to give them more benzodiazepine. So if it's more than 30 minutes, we give benzodiazepine, again, wait 5 minutes, and then we can enroll the patient. Is this clear or confusing? So at least the patient should have gotten, the patient should have received adequate dose of benzodiazepine more than 5 minutes ago, but not more than 30 minutes. What we expect you to do is, as soon as the patient comes, you page the study team, but you don't wait for us to get there. You can, we were supposed to give this a little bit later, so our research coordinator is going to come with some boxes. But you basically pull a box out of the Pyxis. The drugs are pre-randomized, so you don't have to do any randomization or anything. The box is there. There's a Breslow tape in there. So if you're dealing with a pediatric patient and you don't know the patient weight, you can use the tape to estimate the weight of the patient. And then we have a chart that tells you if the patient is 40 kilograms, you have to give them 9 ml of the study drug. So there's a vial inside the box. You look at the chart, 40 kilograms, 9 ml. So this vial might contain phosphatidylcholine, might contain valproic acid, or might contain Keppra. It's all pre-randomized. You just give that medication, that volume, over 10 minutes, and you're done. And one of us will come in and take over. So basically, you pull out the box, open the box, look at the patient's weight, give the volume that correlates with the patient's weight, and hang it over 10 minutes. There are 3 different boxes in the chip. We color code the boxes. They will be yellow, purple, and red, and these are the age groups. So we will have sign there, and you will know based on the patient's age which box to pull out. You open it, and this is the chart. It's actually really, really easy. So you have a patient who has if the weight gray or purple or pink, you don't enroll them. And if the weight falls in here, this is how much the volume of medication, the volume of the vial that you're going to give to the patient. There will be an iPod in the box that you can turn it on. There will be a instruction there how to turn on the iPod, and it will tell you exactly what to do next. It will tell you the time that you start. You put in. It will tell you the volume of the medication, and it will tell you how long the medication has to go. So the iPod is actually going to help you enroll the patients. And inside the box there will be instructions about how to use the iPod. Any questions? So, status epilepticus, convulsive status epilepticus. More than 5 minutes after adequate dose of benzos. If they haven't gotten adequate dose of benzos, you give them benzodiazepines. You wait 5 minutes. If they're still having seizure, you can enroll them in the study without consent. All you can do, you pull the appropriate box, the box that is that correlates with the patient's age. You open the box. There's a chart in there that says if the patient's weight is this much, this many cc's of the vial you have to draw. You draw that, you hang it over 10 minutes, and you're done. And don't forget to page us. Yes?
So the boxes are in the Pyxis in the trauma bed? Which Pyxis?
So we will let you know. We haven't put them anywhere yet, but most likely we'll put them in pediatrics, because we are expecting to have more peds patients. But we'll let you know where they will be. And we will train the nurses, so your nurse will know where they are.
And how do we order it so the nurse can pull it? Do we not order it at all?
You have to order it at some point in the T system and in MICES. After you're after you're done, you just say ESET study medication, and that's it. Yeah, you can order that. We will let you know. We haven't gone live on that part yet, although everything is set. We'll let you know where the boxes are going to be. Yes?
I didn't see, is there an exclusion for seizures thought to be from a toxin?
No.
Because traditionally those shouldn't really get anticonvulsants. If benzos don't work, you intubate propofol.
But wouldn't you give them long-acting second agent anticonvulsants?
Usually
You have to think of
benzo and then propofol.
well, if you can identify the toxin that's causing if let's say if they have INH overdose and you want to give them B6, that doesn't preclude them from getting the second line anticonvulsant.
Yeah, but in general, the anticonvulsants don't work for...
Right.
So, but we'll exclude those later. So we'll give them the drug for everyone, and then if we find out there's a toxin, we'll just make it so.
So when
It's not going to hurt the patient.
Well, I mean, if it's like a Wellbutrin overdose and somebody's having status, you don't want to waste 10 minutes loading something when you should be intubating and giving propofol.
So what Dr. Wiener is pointing out is not all the status epilepticus patients have epilepsy. Not all of them are seizing because of history of epilepsy. There could be some other reasons why they are seizing, hyponatremia, toxins, and other things. And unless you identify that the cause and give them the specific treatment, the seizure is not going to stop. But that doesn't preclude them from being in the study. You can still give them the second line agent, and then when you have time, you can gather information and figure out if you need to give them anything else. else or not, but we won't exclude them at this stage.
Or you could do the other things and then wait. This can be done within 30 minutes of the last benzo dose, right? So if you think that they're non-epileptiform, then you do all the other things,
If it stops,
and then if it stops, it stops.
that's another option. Yeah.
I don't
Yes.
know, just a thought.
If they're being transferred, because there's no EEG monitoring, like downstate or county because of meds, is that
Can you speak
if
up?
there's no bed available for EEG monitoring, they're getting transferred, is that understood?
Do we transfer anybody for EEG monitoring?
It seems like your surgery is very complicated status.
Usually if you people that we transfer are people that we treat, we give them second line agent, we put them on propofol and other things, and they are still seizing. Those are the people that we transfer. That doesn't mean we can still enroll them in the study, and then after 1 hour, we assess the outcome, and if you think that the patient is still seizing, then you can think of transferring or sending them anywhere. It's highly unlikely that you will transfer anybody within 5-10 minutes of coming to the
And those patients are usually the non-convulsive seizures.
Correct,
That
correct.
go for EEG monitoring.
Right. Remember that if you have patient in convulsive status and you give them medications, they might stop having convulsions. They might be actually in non-convulsive seizure now, and it happens about 20 to 25% of the time. Something to think about. And then in those cases, you really need EEG monitoring, which unfortunately we don't have in the ED.
And they're excluded, non-convulsive patients, right?
If you're suspecting non-convulsive seizure, you cannot enroll them. It has to have. There should be an element of generalized tonic-clonic seizure. Any questions? Yes.
What if they're on early on an epileptic? Early on.
That's fine. That's fine. Because A, you don't have time to ask them what they are on. They are in convulsive status because the patients are altered. In our experience, most patients come without any family members, and plus giving them one single dose of anticonvulsant in addition to what they are on, it usually doesn't hurt. But if for any reason the patient gets the medication on the way, it's highly unlikely, but EMS gives them phosphonatoin, or they get something on route, or then they're excluded. Yes.
Just quick question. Are there other centers involved in this study, and how long do we think it'll take, and what's the goal and number?
Perfect question. There will be, the sample size is about 800, 790 something. And this is a net study, this is a neurological treatment trial network, and there are 18 or 24 centers that are enrolling patients in this. This is a NET and PCARN. PCARN is the pediatric emergency network. So this is a multi-center national study. We are expecting to enroll about 1 patient a month, because we don't get that many status epilepticus cases, and not all of them are resistant to benzodiazepines. So we are hoping to enroll 1 patient a month. And the duration of this study is going to take about 4 years. Other centers have already started enrollment, and we are about a third through the sample size. And another interesting part of the study, Dr. Ferrari, do I have 2 more minutes? Another interesting thing about the study that it has adaptive design. So traditionally, you randomize the patient into 3 groups, and you don't look at the data until the end, right? That's what the statistician prefer. In this case, we are actually doing adaptive design. So every 100 patients, we're going to look at the numbers and see what drug is more effective and what drug is less effective. And we will allocate more patients to the group that is showing more benefit. So that the trial will be more efficient. So every 100 patients, we look and see if one drug is doing better, we will allocate more patients to that group. So at the end, we might have it's not going to be one-to-one distribution of patients. One group might get more patients than other. This way, the study will be more efficient and more likely to produce useful results. Thank you very much. We will, I apologize in advance, but we will probably repeat this again soon to the right people of enrollment, and you might get emails from us. But again, this is a really practice-changing research study. This is not just another publication. This is something that your patients will benefit. It will be in the guidelines. You will know exactly how to treat your status epilepticus patients. Thank you so much.